Good morning and welcome to this webinar on sharing risks and benefits. Just going to do a couple of technical checks first of all. You should be able to hear me and see our presentation. If you've got any problems with your audio or anything like that, please speak to your own IT department, and we're pretty sure all our audio is working this side. So this webinar is part of a series of webinars and masterclasses on delivering integrated care. They've been organised and funded through the Better Care Support Team and delivered by the Social Care Institute for Excellence and also PPL. My name is Iris Steen. I'm Head of Marketing and Communications at Sky, and I've got my colleague Joe from PPL who will be running the main presentation. Just to make you aware, we are recording this event. And that means that if you do take part by adding information into the chat box, and I hope you will, you can add comments and questions, that information will be recorded as well. The webinar will be published on the Sky website over the next couple of days, and we'll send out a link to that recording to everybody who's registered and interested in it. Once again, I really would encourage you to add comments and questions as we go through the session. There are some natural breaks that we've built in for those questions, and if you haven't got questions, I have. But I'm now going to hand across to Joe for the main part of the presentation.
So, good morning everyone. Thank you so much for your time and thank you for joining the session with me today. Just before we start, I just wanted to say that because we've got quite a sort of range of audiences today, I've decided to keep this sort of at mid-level. So if you feel that there's either too much detail or not enough detail or technical information, please just let us know, and I'm happy to be in touch with you afterwards. So the agenda for today. So there are three things that I want to get out of the session today. And the first thing is that I know, and I think everyone sort of would agree with me, that risk share can be difficult. However, it is a very important and quintessential part of integrated care and working together, and I'll explain more in detail. The second thing that I want to get across as an objective today is kind of Joe's very simple two-part framework to approach sort of risk share and benefit share planning, and then sort of aligned to sort of the bake-off theme. There's 5 key ingredients I think is important to making this not only start it, but to actually make risk benefit sharing work. And what we've got here is just a quick summary of what this session is, and if you do sort of download this presentation or look at this again, you'll be able to sort of look at this in more detail, but I will be covering this in the next hour. So it's when I was first asked to kind of look at risk and benefit share, it was a difficult one because I didn't know where to really start and where my starting point was, and I guess I really had to think about this and really think about what is risk and benefits share. And I think for most people, it could be sort of a document, or it could be something that's done as an sort of afterthought. But really for me, risk share is about 2 things. As a Canadian, I always think of myself as quite a pragmatist. And when I think about benefits and risk share, or risk share and benefits, I really think about what I can really get out of it, because really, it's really there to incentivize better system outcomes. And if you do it, and if you do it well and do it right, it is such a great tool to incentivize colleagues, partners to get the best out of collaborative working. But also from risk and benefits share, the other thing that really it's there for is that what happens if your plans don't materialize. And I guess that's the sort of second part that we'll be covering today. I've got a sort of a standard definition there, which you can sort of read. But I guess the key point is, why is it important? I think where we are right now with the system and where we are in terms of resources and money, we need to be able to work together, and we need to be able to share resources. And when we share resources, that inextricably means that we're going to be sharing risks, but also benefits as well. And I suppose it's interesting, and I thought that this is great, that risk and benefit share was actually included as part of the BCF. And the reason why I think it's important is because it really forces forces sort of partners to really think about that joint plan. And it really forces sort of local systems to really think about incentives and having shared objectives. And the other thing that's really important as we sort of move into this is sort of the recent announcement of the additional social care funding as part of the BCF as well. And I think this then really requires us to really think about how we put this together. And, you know, in all sort of good practices, either in this country or internationally, in order for this to work, you need to pool funds together. And that pool fund requires you to have a risk and benefit share in it. And those of you that are already sort of, those of you that are already working towards an accountable care sort of setup as well, this is very important because in order to have accountable care work, which accountable care is really focused around three tenets. One is around population health management. The other one is around individualized sort of care, and the third tenet, which is around sharing resources. So it's that third tenet that you require this to sort of work well. So the other, one of my colleagues asked me sort of, how do you really break this down? And I was thinking, you know, there's a really kind of easy way to kind of look at this, and I hope that on the left-hand side of the slide that you've seen sort of this framework before. If you've already done project management or anything around sort of budget risk management, this is probably familiar to you. So the way that we kind of look at risk and benefits, you can kind of start at the service or the project level. And then when you think about all of the risks at the project and service level, then you would sort of bring that together at an organizational level. And again, people are used to working at organizational level and managing risk across. But really what we're really focusing on this sort of topic, if you will, is the system level and how we share risk together across different organizations. The way that I kind of thought about this, and I've used as part of the sort of Better Care Fund sessions, was taking a practical example around system resilience. And if you think about your system resilience sort of plans locally, my way of kind of putting an example around this is, for example, at a service or a project level. So most of the system resilience plan will have some sort of A&E admission avoidance scheme. So for example, you might have a GP in the A&E scheme. At a project level, if this works, or if you're able to sort of get a GP in and able to avoid admissions, then you've kind of reached the benefits of that. If, for example, you're not able to hire a GP and you have that post vacant for 6 months, which means the service isn't live, then really at a project level, that project is at risk, and that's the risk at the project. But then if you start kind of thinking at an organizational level, and you start thinking that actually, thinking about the whole hospital, if your front door isn't working very well, and that's not working, then you know that's actually going to start affecting sort of upstream as well in terms of admissions into the inpatient wards, and you know that's going to start affecting sort of discharges as well. So you can see kind of in terms of benefits and risk share, it's about sort of mapping those risks and benefits as well. And when you're looking at that at an organizational level, that's where sort of these risks, you start building them up, if you will. And then when you're looking at the system level, then that really is, if you're not able to handle sort of the front door of people coming to the hospital, not able to discharge. And then this is going to start putting sort of stresses on sort of impact into the community, into primary care as well. So as you can see from that example, what you're doing, how you're looking at risks and benefits is by mapping sort of at the bottom level and mapping it upwards. And I think this is where a lot of the challenges where I've worked with other local health economies lie when people start looking at sort of risk and benefit share. I think people really start right at the system level and don't really think about sort of how all the contributions are sort of added from all of the different schemes, if you will, from the BCF. There was an organization, not an organization, but a local health economy that I had worked with, where this was really acutely aware, where I saw this. The acute trusts, the local authority, and the CCG could not agree on the risk share and the risk and benefit share. And I think one of the reasons why they couldn't do that at the top level was because there was about 50 or 75 different schemes that were contributing to sort of their BCF. And I think if you're not really clear about sort of how those schemes are contributing, it's very hard to sign off on that risk and benefit share at the top level. So yeah, this is a way to kind of look at sort of risk and benefit share, looking from sort of bottom up, if you will, and building it up. Traditionally, from a BCF risk share perspective, there's really two ways to, there's sort of across sort of the system, there's two ways of looking at how you share risks and benefits. So you can either take that from an activity commissioned perspective. So whoever commissions the most activity will take on the most risks and the most benefits. Or you can do it based on a contribution or pro rata one, which I find is quite simple. So you say it's 33%, 33%, and 33% across three partners. That's a way as well to kind of look at how you sort of articulate that sort of risk and benefit share in terms of financial terms. When I've done this in the sessions, people always ask me, why do you always talk about money all the time? And I say that actually it's the money that is the tangible thing that you can actually measure. And that's why sometimes when you talk about risk and benefit share, you talk about money, but it really is about the outcomes and it is about the risk, but it's the money that you are articulating because that's what flows between organizations. So,
yeah, we're just going to take a pause here, really. We're interested in knowing if people have a risk and benefit share arrangement locally, and if you have, would you be willing to share that, and we can arrange that. Obviously, you can type comments and questions in on what Joe has covered so far. But I also wanted to ask Joe, in terms of what we've learned from the work around the country, how common is it for people to have a local risk and benefit share scheme in place?
So I think as part of the previous BCF sort of iterations, I think everyone should have I would probably say it's more of a risk share around non-elective admissions as part of their BCF schemes. But there are actually, I think it's a strange one because I think this, even people who have in areas where they have really good sort of risks and benefits share schemes, I don't think people even know they have it, if that makes sense. And some of the examples that we'll be talking about are some of the examples I really like that really sort of use risk and benefit share in a very good way, in a simple way.
Okay, that's great. And as I said, please do add comments or questions as we go through, but we'll move on to the next part of the presentation.
So the first example that I wanted to use is Liverpool and South Sefton. And one of the reasons why I really like this example is because it's quite a simple sort of, it's a simple sort of application of risk and benefit share that I think is really effective. So what Liverpool and South Sefton did was that they essentially put one block contract together with 6 NHS trusts over 2 years. And I think here it says 1.5 billion, and I guess it just depends on the variation, but we were up in St. Helens, was it 3 weeks ago, Iris? Yeah. And I think colleagues had told me that it was about 750 million, regardless of how big that contract or not. What's different here is that instead of paying by activity or payment by results, the commissioners and the providers have agreed that actually, rather than sort of, spending all your time, trying to manage the risk of upturns or downturns, let's just, we know how much resources we have, and why don't we put it together as a block contract, and why don't we make sure that actually this is fair for everybody, and that in this contract, the providers receive 1% real-term gains for 2017-18, and again, another increase of 1% for 2018 and 19. And from a contractual perspective, it's it's quite straightforward. I mean, I say it's straightforward in terms of concept. I'm sure the contract itself is not straightforward. But what was really delightful to hear from colleagues, and they're both providers, commissioners, and the local authority, almost in a way, is that everyone just stopped spending time around arguing around sort of like, contracts, activities, surpluses, and what people were doing was actually, now that they know how much how much income that they're going to have, everyone was actually now just focused on actual service transformation and working together. And I think what's happened and what this has allowed is a change in behavior in terms of how people talk to each other. Now that everyone knows that actually, we're kind of in it together now, people have been able to actually talk constructively about real service transformation that's going to work, because it's not about sort of who's going to gain from this, because everyone will gain from it, because everyone is in one sort of risk and benefit share, if you will. And it was really nice. And I think one of the cautions that colleagues said to me was that, this is the first year, we'll see how it goes. And, and we'll reassess the situation. And again, that's very normal, because, you can set something out, but you've got to sort of see how it works, and you need to adjust it and tailor it. So that's something that's happened in the last year. And I guess we wish them sort of the best of luck. The second example that I want to use was around the Oxfordshire mental health outcomes-based care model. And again, this is a different way of looking at this, and this is definitely one of my favorite ones, because I'm a firm believer in outcomes-based sort of care. So what Oxfordshire did across commissioners, providers, local authority, citizens, service users, was they got together and they defined what were the key outcomes that they wanted in terms of a successful mental health sort of service or function or intervention. And what they came up with was 8 outcomes, and such as people will live longer, people will improve their level of functioning, and this represented what they want from an overarching sort of mental health system, if you will, in Oxfordshire. And what's interesting about this example is that there's a weighting in it as well. So you can see for outcome 2, there's a 20% weighting for people who improve their level of functioning. Whilst if you look at sort of outcome 1, people will live longer, it just gives sort of a weighting and a sort of emphasis in terms of prioritization around this. But where the risk share occurs here is that it's a risk share in terms of bringing together all of the spend into sort of one view. And the risk share is that 80% of the contract is based on the delivery of activity and paid up front, and 20% is based on outcomes. And the reason I've had questions about this in the session, and people are like, why is this a risk and benefits share? Because what's key here is the incentivization and the incentivization for benefits. And that 20% of incentivization is what creates that sort of, where it's not just looking at risk, but it's incentivizing benefits. And the other part for this, the other thing about this example that I really like is that the lead provider for this is actually a third sector, voluntary sector organization that's leading it. And essentially the acute mental health trust and other providers are subcontracting to the lead provider. And that arrangement helps sort of drive this, where it's the lead provider is able to drive these outcomes together and work together in an integrated way. So again, another way of looking at how you come together in integrated fashion.
Okay, great. Thanks for that. So again, just gives us a little opportunity to look at some of these examples. I don't know if you want to continue on about the Torbay example, and we'll come back to some questions. But if people can start to just consider, how would these examples work locally? What would be the challenges for you? So if you have those in mind, and I'll pass back to Joe on Torbay.
My third example for today is the Torbay ICO example. And the reason why I am using this example for today is that I wish there would be a link to, is I think that the every session I've been to at the moment, people have asked me, Joe, is there actually good risk and benefit share sort of document around that is really good? And for me, I think the Torbay ICO one is really good. And the reason why I think it's really good is because it follows sort of a very key approach of looking at it. And I'm just going to sort of go through quickly, but you can come back to this slide later. Just to give you a quick overview of what the Torbay ICO sort of risk benefit share is. It's a 5-year risk and benefit share that started in September 2015. It's a risk share between the Care Trust, Torbay Council, and the 2 CCGs in Torbay and South Devon. And this risk and benefit share includes all planned urgent care activity, CHC activity moving forward, not retrospectively, community, adult social care, public health, and the CARE Act. And things that have been left out of it that are a little bit more contentious is, and I'm sure for most areas as well, is the the CHC retrospective cases, which is always a contentious one, and equipment. So that's sort of the sort of scope, if you will, of the Torbay sort of ICO risk share. And what I really like about this risk share, because it really sets out the 5 things that you need to do. First of all, is agreeing a baseline. You need to agree a baseline of your starting point. And again, in the sessions that we've done before, people are saying, well, some folks are in deficit, some are not in deficit. So this is why agreeing a baseline is really important, because you're agreeing from a starting point so that you are not sort of funding someone else's deficit or otherwise. The second one is committing resources to it. So it's about sort of how much resources, money that we're putting into this. And then with all of this, you need to have a benefit, and the benefit from here is around delivering service efficiencies, and that being the Care Trust delivering the efficiencies. And as part and parcel with all of this, and we'll talk about this as part of the sort of 5 ingredients later, is that you need to manage the variance. And it will happen. Your variance, you will either be in deficit or in surplus, and that's something that you have to manage, and that has to be reflected within your risk and benefit share. And then changes to risk share contributions. As I said, this is sort of a living and a live thing. So if this isn't working, you need to change it, or if someone decides to put additional funding into it, then you need to change this. And what I like about the Torbay example as well is that for either deficit or surplus, so either way, the risk share is based on proportions. So 41% is the CCG, 9% is 41% is the CCG, 9% is the local authority, and 50% is ICO, which is the provider. So if there's a deficit, that is how the contribution has to be made. But if there's a surplus, that's how the reward is sort of divided as well. And then one last thing, the reason why I like this example as well is just very recently there has been discussions about the local authority pulling out of this because of their financial situation and the burden. And hopefully with the sort of new adult social care input as well, that might change. But again, just a very live, real example of how this works. You can put a plan out, but you've got to sort of vary it and manage that in a mature way.
Okay, thanks for that, Joe. And I think, one of the questions I had was around that issue about, how do you get all partners to engage? We have been hearing in some cases that it is difficult to get adult social care and the local authorities involved. But, how can we make that work?
Yeah. So, I think it's very difficult, isn't it? I think if you're in a local health economy and you have a great relationship already, then you're very fortunate, and that helps it. And if you're in a situation where you don't have that kind of working relationship because you haven't built that trust yet, then I think one of the things that I really suggest is that we kind of step back from thinking about this as a risk or benefit share or being a financial piece, but really think about the outcomes in the population, taking a more population health approach to this. So, it's really hard when you're just talking about money or services or functions, if you will. But really, I think the way to really think about this is to think about the people and the cohort of people. So take older people, for example. It's very difficult to discuss money and services because we're just talking about funding more services. But if we start focusing on the people and the needs, this is how you start shaping the services and the service redesign, and how you can and the contributions that you can make together and the benefits together. So I guess my answer to you, Iris, is really stepping back, looking at the people, looking at the population, and really rethinking about how you're spending the money and the schemes around it. And I think that will help guide you more towards a more objective conversation. And that's the starting point.
Okay, that's great. Also, just to remind you, I know there's quite a lot on some of these slides. We are sharing them afterwards, so don't panic. You'll be able to see those examples later. So we're now going to move on to the next part of the presentation.
So I get teased for this every single time that I do this in the classes, because I call this the sort of the Joe's simple two-step approach to looking at benefits and risk share. The first thing that you need to think about is, do you have a plan for? And I think this is where everyone falls down, because the risk and benefits share has to be an underpinning of an actual plan. And if you don't really have a clear plan, you're not clear about the benefits around it, then it's going to be very difficult for you to put together a risk and benefit share. So the key questions to ask yourselves when you're doing this is, what do you want to achieve? What are the outcomes? Who is involved in this? Who are the parties? Is it all providers? Is it the CCG? Is it the local authority? The thing that people challenge me in this is that, it's like trying to get somebody in here and they're not going to win. So, it's like forcing them in. And I always say that, and people again laugh at me because I am not married, but I think that all marriage is a partnership and everyone has to win in it. And so what I say is that if you have a plan and you want somebody to do something and they're not going to benefit from it, then there's really no point of actually putting a plan together for that. And if your plan doesn't benefit everyone, then you really need to rethink of your plan. Then you go into the financial benefit. So it's the risks, because this is where you have to convince your finance colleagues of why this is a good idea. So you have to think about all of the risks of it not happening. So the last example I said, what would happen if the GP front door doesn't work? What is the risk and what is the financial risk around that? So it's about understanding that and being able to articulate that. And what are your financial thresholds? So, if you're a local health economy that's a bit flushed, maybe you've got more of a financial threshold. If you're not, then it's less. And it doesn't really matter, because whatever the case, your risk and benefit share has to reflect that and what your thresholds are. And as anything, you need to think about the worst case scenario. And as a trained engineer, this is how I always approach life, is that every decision I make, I always think, what is the worst case that would happen? And really, from a financial mitigation perspective, it is about thinking about that. So if all of this doesn't work, and what is the worst thing that could happen? And you're clear about that, and you're clear about how you're going to manage that. And that's key. So that's around the plan. And then the second part is how you manage your over and your underspend. So we talked a little bit about that as part of the Torbay example. So is it going to be withheld from the pooled fund or not? My suggestion always is it's got to be in a pooled fund, because if you're managing this separately, then it's not really a true risk and benefit share. And the whole point of it is, and as I said before, the pooled fund is very important, not only for the BCF, but it is important if you're moving towards accountable care in any form or shape. And how and when is it paid in? So most places, the suggestion is always quarterly. So it's about monitoring sort of where you are in terms of your position and trying to do that on a quarterly basis rather than trying to do it on an annual basis. And the reason why I say that is because the monitoring part is really important. You want to see if this is working or not, and being able to adjust things sort of in flight, if you will. Who decides how it's spent? So you need to have a key person or key organization that's responsible for that. And if their targets are not met, then who contributes to it? So I think, again, the Torbay example is a very good one, because if the targets aren't met, then it's a proportionate split based on the agreement. And what happens to an overspend? And if you're in a situation where, and there are places that have had overspend, believe it or not, it's about reinvestment, I suppose, and it's how do you want to reinvest that as well. So that is my two-pronged, simple approach to this. And as you can see on that sort of strange but pink flagpole is that no one size fits all. So just remember, you've got to make it local and really make it simple and be specific, because if it's too hard to understand, then you're not going to get the buy-in for it. Right. So this is my second last slide, and this is my sort of bake-off example, but somebody told me that also bake-off is not really sort of on trend anymore now that it's moved to Channel 4, so I'm going to have to find something else to sort of use here. So, so if you look at, from my own experiences, from the feedback, from sort of all the sessions that we do, and also just from best practice, both nationally and internationally as well, there's really 5 things that you really think about to make this really work. And the first one is transparency. And this is key because if this is something opaque, it's really hard to manage. And when I say transparency, first of all, it's about the numbers and figures. So having a clear baseline and clear performance measures that can be tracked is really important, and really important to be proactive about it. This is why I talk about making sure that we do this on a quarterly basis, making sure that we're able to deal with issues in flight, and making sure that we can change things. And this is not just for your risk and benefits share, but this is for your BCF program or for your integration program. This is good practice. And as I said before, the reason why you have this is to have a common purpose. And if partners don't have a clear common purpose or outcomes that you're trying to achieve for your local population, then this is going to be really difficult. Yeah, I think that's self-explanatory. Then the third one is around shared understanding. And when I say shared understanding, I mean that in sort of different levels. So I think it's different, and it's about looking at across sort of all of the different levels. So for leaders, for example, there has to be that trust and that leadership to be able to manage this at the top level. And then and even with staff as well. And I think this is where a lot of this, in terms of schemes not being successful, for example, if you take sort of a discharge to assess example on the ground, which involves hospitals, which involves out of social care, involves community providers, therapists as well. One of the things that the staff on the ground and on the wards have to understand is that once somebody is medically fit, they can leave the hospital, and they have to trust that the receiving end will be able to manage that. And the reason why I use that example is that if the hospital staff do not understand that if they don't actually start discharging people through this way, that actually that scheme isn't going to work. And it's really important. And I again see this in a lot of places where the schemes are sort of understood by potentially the operational managers and the commissioners, but because the staff don't truly understand how that flows in the system, that's where it could fall down as well. And the other thing about shared understanding is understanding, I guess in that example, is how you can influence the risks and the benefits. Because the key thing here is that it's about influencing that. And it's what you can do sort of day to day to make sure that you are achieving those benefits, rather than sort of just waiting to realize the risks. The fourth one is around governance arrangements, and keep it pragmatic, because I think if you already have sort of a joint commissioning or some joint committee, just use that as a board, and just change the terms of reference for that group to manage this as well. Again, don't make it overly complicated. It just has to be a place where you've got the right people to make the decisions and manage that. The last one, and probably like the most important one, is trust. And I guess I've been working sort of in health and social care now for about 12 years now. And the first time when my boss told me that actually, health and social care works based on trust. You can put as many systems in place, you can put as many agreements in place, but it all is around that trust. And that is what sort of helps people take risks. It helps you sort of be innovative. And really the personal chemistry between sort of leaders and also staff on the ground is really important for making this work. So that is almost like the butter in the scone. The last thing I just wanted to kind of, for any of you who were just, now that the sort of guidance is sort of published, is that this year there is no mandatory or mandatory risk share that you need to put in place, which is which I think is a good thing because it makes it allows you the opportunity to really tailor this. However, where local areas or health and wellbeing boards plan to reduce non-elective admissions above the CCG operating plans, then there is a suggestion that you consider putting an equivalent of the NHS out-of-hospital ring fence funding in place, just in terms of mitigation. So that's sort of the guidance, if you will, around that. So good news to some, I'm sure. Yeah.
Great, thanks very much for that. And see, we got a question here from Sally White. Governance of any scheme is often at the highest level, for example, a joint commissioning board. So do you think that you get sign up to a risk and benefits share at the lower levels, or the doers of the other organisations? In terms at front level, if you've got a risk and benefits scheme in place, it might be relatively isolated, a high piece of governance, but does that filter through to sharing risk and benefits at a more operational level as well?
Yeah. I think this works differently everywhere, and I haven't actually, I think where this works really well is like places like in Valencia, where they've got the Ribera Salud system, where the risk and benefits is cascaded down to processes, systems, and behaviors. I haven't really seen this sort of in my own experience, and I think the agreement itself is at the highest level, really, but really it's that cascading of the message and understanding the contributions to that is what needs to be sort of communicated down to the operational levels. And it doesn't actually have to be communicated as a risk and benefits share. I think that is actually communicated as part of that scheme, to be honest, and how it works and how people understand the successes of the scheme or the risks of the scheme.
Okay, thanks for that. And again, if you've got any other questions or points, please put them through to there. And we do have some international best practice examples. I think Joe's just referred to Valencia. But I don't know, Joe, if you'd like to mention any other ones on international best practice.
Yeah. I think anywhere where there's there's this sort of accountable care type sort of setup as well. The one that I really like is a Fredericia model in Denmark, and that one is I think Fredericia has about sort of, I can't remember the population, we're about 80 to 100,000 people, but 20% of their population is over 65, and they have a really good sort of what they did was very interesting, and they forced all of the system leaders to work with each other 4 days a week and only focus on making the older people service work. And what they did was, again, it was the pooled money and what have you. But I think the key thing there, why I think it's a good risk and benefit share, is that they decided to completely revamp their older people services. So it became more of an independent service, where rather than providing care for people or putting home adaptations or providing lots of care, what they did was really think about this from a therapeutic and from a social perspective. And what they did was they actually tried to get older people back active in their communities again. And they went from spending about 262 hours on average of care to about 26 or 28. And I can send that out in terms of the case study as well. That's a really good one for me about risk share. And then other ones include a lot of the HMOs in the States as well work under this sort of concept as well, even though they're privately funded, but they work kind of very much sort of in a similar way as the NHS in terms of it's a limited budget. Yeah.
Okay, that's great. I mean, some of the issues that we've been thinking about is really, what are the benefits of using an arrangement like this locally, and what are those challenges? Joe, would you like to just reflect back again on the wider benefits to a good risk and benefits sharing agreement?
Yeah. I mean, I think for me, just going back to the Liverpool and South Sefton example and the Oxfordshire mental health example, it's not the risk and benefit share on its own that makes it successful, but it's a critical enabler of it, if that makes sense. Without that sort of very clear and a very sharp sort of that kind of clear intention of how we're going to use our resources and being clear about how we'll manage it. I think that's why we do this. Does that make sense?
Yeah.
So that's what I would say is the benefit. And also the other thing as well is I think if done properly and done in this way, I think this framework gives you a really good, this is a good framework, if you will, to really bring partners together, finance folks, numbers folks, clinicians together. I think people understand this, and it's a simple framework to work through. And again, this is why I think it's helpful to do this, even if you don't actually get a risk or benefit share agreement at the end of it. It's just a very logical sort of way. Sorry, I'm a trained engineer. I like logic. So.
Okay, that's great. I mean, and again, we're hearing sometimes that, that all sounds great, but that won't work here locally because maybe there's poor relationships between partners, or that, there's deficit issues. Again, what would you say to areas facing those kinds of challenges?
Yeah. So I think most areas that have great maturity and great relationships and trust, they all start out small. So I think what it is don't go so big. Try to work on something that you think will really add value, and don't do something so complex that you can't deliver it. So that's what I would say. Like some people look at sort of joint commissioning sort of schemes. Maybe perhaps you want to look at sort of bedded care and look at how you're commissioning intermediate care beds and nursing residential homes, things that cuts across high cost, but actually really helpful. And really think about how you can shape that together as both a local authority and also as CCGs, but also with providers as well, and really look at that in a different way. So that probably wasn't the easiest one to look at, but it's a starting point. It's making sure that you find something that really for all partners, it's kind of it's the issue, and trying to work on it to resolve it together.
Okay, that's great. I mean, if there are any other pointers or questions, please do bring them through. But also just to let you know that within the document we'll share, there is going to be a range of links that you can access, and useful products and tools. And I just quickly highlight the Better Care Guide, the Risk Sharing Quick Guide. We're actually updating that at the moment, so a new version of that will be out over the next month or two. And if you do have examples and you're willing to share, ourselves and our colleagues at the Better Care Support Team, I know, are really interested in hearing about those examples. And the whole purpose of these events and the webinars is to share information about what's happening locally, and recognizing that it's emerging practice. There's no perfect way of doing this. I think, as Joe has said, you got to start somewhere. So start small if you can't go for a full risk and benefit share agreement, but do start to explore this. It really is an important way of helping you to work in an integrated way, as well as meeting integration kind of targets. So we will share this. All these links are available. I'll just give people a couple more minutes if they want to add any more comments or questions. I do hope this has been useful, and we're just going to pop across a little short poll, a little survey for you to fill in, if that's all right, to let us know how valuable you found today. That's useful for us to know, and obviously very useful for the Better Care Support Team to know, in case this is a kind of effective way of sharing information with you on an ongoing basis. And I just wondered, Joe, if you wouldn't mind just summarising maybe your top 1 or 2 pointers that you would give to somebody starting off on this route.
I think the first thing is, especially colleagues that are not really involved in the finance side of things, especially if you're more involved in the better care side of things, is go talk to your finance colleagues, look at the contracts, look at what's happening, look at the plans. And the first thing is to really just understand sort of, where the money is being spent, the activities, look at your schemes and look at the finance. That's where I would start. And then I think the second thing that I would really kind of do is that to go through the schemes in your BCF or your integrated care plans or whatever plans you call it, and really map out the risks and benefits and that flow and how that works. And I would suggest that's your starting point to really getting getting to terms or grips with this. So.
Okay, thanks for that. And just again to emphasize, we'll be sharing all this information on the Sky website and also through the Better Care Bulletin. The last in the series of these webinars will be on the 10th of May, and that's looking at the thorny issue of data sharing, both in terms of how it can support decision making around commissioning and measurement, but also in terms of how it can support direct care. And we're really pleased that we've got contacts from the Local Government Association, NHS England, and a commissioning support unit presenting on that. So if that's of interest to you or your colleagues, please do let them know. That's on the 10th of May. Again, information about that you'll find on the Sky website or through the Better Care Bulletin. So if anybody else has any more questions or comments, please send them through. And obviously you can contact us anytime. I'll share the Better Care Support Team email address again so that you can access us there. So just to say thank you very much for joining us today. As you're already registered for the webinar, we'll have your contact details, so we will share all of this information with you, and hope you have a good weekend.
Yeah, I just again wanted to thank everyone for your time. Thank you very much, and as I said, have a lovely weekend and good luck with your plans.